Good afternoon, everyone. I'm Amy Krause, and I'm a member of the Cancer Center Education Workgroup. Thank you all for joining us today. Your audio is muted, and we ask that you please remain muted during the presentation. We will have a Q&A session afterward, and you will be able to unmute your audio to ask questions. We also encourage you to use the chat feature to pose questions during the presentation. We will try to get as many of your questions as possible in the Q&A session. In the chat, you will see a link to sign in for this session. Please take a moment to complete the sign-in. This is extremely helpful to us to measure attendance. If you signed in, you'll also receive an emailed anonymous survey following today's presentation. Please complete it, as your feedback is extremely helpful to us in planning these events. I have the privilege of introducing today's speaker, Dr. Martin McCarter. Dr. McCarter is a professor of surgery at the University of Colorado Medical School and a member of the University of Colorado Cancer Center. After a residency in general surgery at the New York Hospital Cornell Medical School, he completed a fellowship in surgical oncology at Memorial Sloan Kettering Cancer Center in New York. After starting his general surgical oncology career at the University of Colorado in 2001, his clinical practice now focuses on the treatment of cancers of the gastrointestinal tract, sarcoma, and melanoma. He is the surgical program director for the esophageal and gastric multidisciplinary program. In 2018, he assumed the position of vice chair for strategy and program development in the Department of Surgery. Current research interests include understanding the mechanisms of tumor-induced immunosuppression and the development of targeted therapies for gastrointestinal cancers. He is committed to improving patient care through a team-based, multidisciplinary approach and advancing medical knowledge through both clinical and translational research. Educating students, residents, and patients remains an important part of his professional passion to pay it forward. I will now turn the time over to Dr. McCarter.
Well, thank you very much, Amy and Jessica, for the invitation. And I really, just hopefully you guys can see my screen now. A cancer technology, surgical oncologist, more than a cancer technologist. I will assume
we can see it.
That's working. Okay. Well, so I was asked to give a talk today about surgical oncology, and realize that maybe not everybody understands what a surgical oncologist is. You might have heard the term, or maybe you know some surgical oncologists, but there's a little bit more behind it than just that term. And I thought I'd just kind of share some thoughts about what it is to be a surgical oncologist, what makes that surgical oncologist a little different from some other areas of cancer treatment, and in particular other areas of general surgery. So there really are no stupid questions here. So please, feel free to ask anything that just sort of pops in your mind as I go through this. Chat, write it down or save it for later. The other thing is that I think of a cancer surgeon as somebody who specializes in trying to remove the cancer, for sure, but that is not all that a surgical oncologist does. And in fact, in theory, all cancers could be removed with an operation, right? But it doesn't always make sense to do so. And I'll walk you through some of the thought processes behind that. The other thing about it as surgical oncologists is that we tend to be complex problem solvers, because some cancers are pretty straightforward, but many are not, and require a lot of thought and planning and integrated care to try to figure out how to best treat it. And I put up a few pictures here that show some of the spectrum of what we deal with, from very huge tumors in the abdomen on the left side to some smaller tumors, but in a bad spot on the leg and the right side. And then down the middle is kind of all the other stuff in between, all the molecular signaling, the biology that goes behind into the tumor, and trying to understand all that. And so that's a lot of what a surgical oncologist does. And I'd point out that not all cancer surgeons are surgical oncologists. In fact, most general surgeons do some degree of cancer surgery. There's out there, particularly in non-academic centers, out in the community, lots of general surgeons do, and they do a fine job of breast cancer surgery and colon cancer surgery and maybe some skin cancers. So a lot of that is done outside, but the difference is that a surgical oncologist has a more broad training specifically in cancers, whereas a general surgeon is covering a huge amount of ground, from just colonoscopies to diverticulitis to gallbladders to appendixes and that kind of thing, and hernias. So it is a smaller part of their practice.
Dr. McCarter, sorry, can I
Yeah.
interrupt real quick? On our end, we're seeing like your display. If you go up to display settings, I think
Yep.
it says like reverse.
Uh, let's see, display
Um,
settings,
yes, swap presenter.
swap,
Yeah.
there. Is that
Great.
better?
Yes, thanks so much.
There you go. Thanks. Thanks for pointing that out. Um, so a surgical oncologist typically has spent 5 years training in general surgery. In fact, is board certified in general surgery. But then they go on to spend another 2 or 3 years of additional training in a specialized fellowship. And surgical oncology covers a broad range of cancers, mostly in the abdomen, but skin and sarcoma cancers as well. In general, the training does not cover other subspecialty areas such as neurosurgery or gynecologic oncology, or even GU oncology or thoracic oncology. So each of those areas has their own specialized training, and within them, focus down on cancer specifically. Now, surgical oncology has existed for quite some time, but only in 2011 did it become its own specialized area within general surgery, to the point where they have now a board certification within what's called complex general surgical oncology. And I think the emphasis there is just that, some cancers, again, skin cancers, some colon cancers and breast cancers are pretty straightforward. Others are not. And so that's the emphasis on the complex part of it. And currently, there are about 34 training programs in the country that generate about 70 or 80 surgical oncologists per year. So it's still a relatively small number, considering that there are about 1,000 general surgeons trained per year. And one of the other things that really sets surgical oncologists apart is the additional training in cancer pathology. So we spend time with the pathologists, we spend time with radiation oncologists, we spend time with medical oncologists, really digging into their specialties, understanding their perspective, how the surgery affects their treatments, and vice versa, how their treatments affect surgery. And so we have a much deeper understanding of what the implications of all these treatments are on the surgical approach. And then in the academic setting, such as here, most surgical oncologists then focus on just a narrow number of cancers. So, there's some that focus on a handful. I still have a very broad practice because that's what was needed when I started out here. But as the place has grown, we now have people that, much more specialized in specific areas. And you certainly we have a dedicated team of breast surgical oncologists. We are evolving our pancreas program, and that's a very focused area of surgical oncology as well. But out in the community, a surgical oncologist might still do a much broader practice of surgery. So a surgical oncologist really takes a deep dive into cancer biology, and I'll come back to that in a moment because it really comes down to understanding that biology and how that should impact on the treatment decisions. And we also really focus on trying to understand when a cancer operation makes sense and when it's most likely to provide a benefit. One of the things we try to do is avoid doing a technically perfect operation, but doing it for the wrong reason. And it's a bit like an auto mechanic who may be able to fix a broken timing belt, but that doesn't really understand how that fits in with the rest of the engine and what alterations they make to the timing belt process, or what the new belt does and how that impacts the rest of the function of the engine. And so that's where a surgical oncologist really comes in, because they have a much broader understanding of where the operation fits into the rest of the treatment. And of course, we work very closely with other cancer specialists in the multidisciplinary setting in order to figure out what the best treatment would be for that patient. So another area that surgical oncology differs a little bit is enhanced knowledge about rare tumors. And we in surgical oncology tend to take on some of the weird and wonderful and unknown type things that come down, even if they're not a cancer. It's just undiagnosed or unclear what to do with it, or if there's a suspicion for a cancer, many times we'll get involved with that. But then there are a whole spectrum of, rare tumors that very few people have a lot of experience with. And, I put a few examples here, the Merkel cell carcinomas, some, rare subtypes of sarcomas. In fact, there are, 50 or 60 or 70 different types of sarcomas, but all sarcomas equal about 10,000 cases per year. So nobody has, a huge experience on any one of them. There are unusual lymphomas that occasionally we get involved with. For the most part, lymphoma is not treated surgically, but there are a few rare subtypes. And then neuroendocrine tumors are an example of, a tumor that can appear or come from any place in the body, but can impact, a whole bunch of places. And so a surgical oncologist will often get involved with that. So, the other thing about surgical oncologists is that we have a much better understanding of the evolution of cancer treatments. And you can imagine that, the complexity of cancer care has just skyrocketed. As our knowledge base increases, our understanding, it's hard to really keep up. And that's where, general surgeons out in the community do the best they can. But, honestly, the operations we did 20 years ago for cancer are very different than what we do now. And that's largely because the treatments have changed, the other treatments, the medical treatments, the use of radiation therapy, different techniques of radiation therapy, different ways to treat cancers, not just always cutting them out. Sometimes we can ablate them or destroy them in other ways. So, we still need, good surgeons, but we also know that we specifically need surgical oncologists who can focus on specific cancers. And, a general surgeon just may not know all the latest treatments are available and how that integrates. So, I think particularly in a larger center like this, it's important to have surgical oncologists. So, I made a point about tumor biology a bit ago, and I'd like to come back to that because really, I think where the value added is our understanding of how tumors behave. And as you probably know, tumors can behave in many different ways. There are some that are very slow growing. There are others that are more rapidly growing. And understanding, how that impacts our treatment decisions, how fast somebody needs to get to surgery versus whether they should be treated with chemo or radiation therapy before an operation. The tumor biology impacts all that. And one of the questions that a lot of patients ask me is, how long has that tumor been there? They'll present with this lump that they found, in their abdomen. May not be causing a whole lot of pain, but certainly a pretty big thing. And the reality is that most cancers actually have been present for quite some time before they're detected. Of course, they all different. There are some that are rapidly growing. Leukemias in particular were very rapid. There are some solid tumors that grow rapidly too, but by and large, most tumors, solid tumors in particular, have been there a long time. And there's been a lot of work done on modeling and trying to understand this. And to a lot of people's shock, the best models we have, for example, for pancreas cancer, which most people consider a very lethal tumor, fairly aggressive, it may or may not be all that fast growing, but our best information suggests that most pancreas cancers have been present for about 17 years, somewhere between 15 and 17 years before they're detected. And that, implies that something had been sort of brewing there for some time. So that's, pancreas cancers usually aren't all that big. For the really big cancers, they may have been there longer. It just takes a long time, for the sequence of mutations to occur and the growth signals to occur enough for the tumor to grow. And then there's a whole nother sequence of mutations that occur that allow that tumor to spread to other places as well. So understanding those elements is important. We rely a lot on the natural history of the tumors, but as time goes on, our molecular studies are getting more accurate and better at predicting what the tumor is going to do. So understanding how those molecular studies integrate into therapy is important and will become even more important. The other thing to know, is important to know is where the tumor is likely to spread. If it's going to spread, where is it likely to go? And different tumors have different behaviors, and that tremendously impacts the type of an operation you do. So some tumors maybe need a very close margin, and that's fine. Other tumors need a wide margin, and other tumors need a lot of lymph nodes to be removed. And so knowing where and when to extend that operation is important. Also important to understand, can you remove all the tumor? Most of the time that's our goal, obviously, is to get rid of it. But, sometimes it's not feasible or practical to remove all the tumor, but if you can remove some of it, maybe that's going to help the patient. And so understanding when that's practical is important. It's also important to understand when other structures or functions could be impacted. Of course, our goal is to get rid of the tumor, but we want to preserve as much normal function in doing that as possible. And understanding what the implication of that operation is, removing part of the pancreas or stomach or liver, what does that do to the patient's long-term function and outcome, and how does the operation, how is the operation customized to preserve that function? And then, as some of my colleagues have often said, it's important to separate what we can do to you from what we can do for you. And that's a conversation we frequently have with patients in the clinic setting, because most patients want something done, and you understand that, but the reality is that just doing something doesn't always benefit the patient. So want to know what is the best thing for the patient, not to the patient. And it's also important to understand tumor biology, because a lot of what surgical oncologists do is palliative surgery. So palliative surgery really is, symptom treatment or symptom management. And unfortunately, a lot of patients, present with tumors that have spread widely. And there's a few examples here, but that's not something that can be, cured with an operation. You can't possibly remove all that tumor. On the other hand, if the patient were having specific pain from an area of tumor or bleeding or a blockage, well, those are things that can be alleviated. And so, a surgical oncologist often specializes in figuring out what the best palliative treatment is to preserve quality of life, maybe get them back to a point where they could undergo other treatment. It's one of the harder things we have to do is try to clarify what that goal of care is for the patient. By the time many patients are sent to a surgical oncologist, it's often kind of their last hope, or they're desperate to have the tumor removed, and we certainly understand that. But it's really important to clarify, what is that goal of care? Is it a curative operation? Well, if it's a potentially curative one, there's a lot of things we're going to do, different or maybe willing to sacrifice to get to that point. Whereas if you can't possibly cure it with an operation, then you want to preserve function, and you don't want to sacrifice function or organs. So it's important for both the patient and the surgeon to understand that. And it's also important to set realistic expectations. Again, most patients assume that when they're going to see a surgeon that all the tumor is going to be removed and they'll be fine. But the reality is that that's not always the case. Some tumors, even if they are removed, they have a technically perfect operation, they're still at risk of a tumor coming back again. So it's important to know that. It's also important to be able to preserve hope at the same time, right? That's a lot of what we do. We want to be realistic, but we also want to give the patient the best chance, at preserving whatever quality of life or duration of life they have. And in fact, I would say one of the harder things that we have to do is talk a patient out of an operation. Again, if they're seeing a surgeon, most of the time they're expecting to have that operation, but many times it just doesn't make sense to put them through that operation. And in fact, so one of the ways we do that is to work with our medical oncology colleagues and radiation colleagues, and basically explain that at this time, an operation is not likely to help you. But if somehow we get some response to treatment, and this tumor is still a problem, well then maybe it does make sense to revisit the idea of an operation. So I thought I'd maybe give you a few examples of what a day in life of a surgical oncologist is like. And This is an example of a patient who had a sarcoma involving the inferior vena cava. So it's a large tumor. You can kind of see it in the middle of the picture there. It's displacing the liver, displacing some of the other organs as well. And that's a complex situation. And this patient would typically see a surgical oncologist, but I in turn wouldn't know the biology of this tumor and the goals of the operation. But technically, I'm going to need some help to deal with this. This is not an area that we always operate on, and so I'll engage my partners. In this case, it was the transplant surgeons. So I went to them and asked them to help us design an operation to remove this tumor, preserve the liver, reconstruct the drainage of the liver, and reconstruct the vena cava. And so that's one of the challenging parts of surgical oncology is, understanding, does it make sense to do that? And if it does, then how are you going to get that done and preserve function? This is another example of, working with a combination of radiation therapy and vascular surgery. These are two different pictures of sarcomas that are in the pelvis, and they both happen to involve the artery and vein and maybe even the nerve that serves the leg. And so this is a situation where, yes, technically we can remove that operation, but we want to try and preserve function and give the patient the best chance at a long-term survival. So here's a case where we would use a combination of radiation therapy, and then I would engage our vascular surgeons to help me reconstruct this. So I can get that tumor out of there, but I'm going to need some help reconstructing the vascular supply. And another example of a tricky situation here with a tumor low down in the pelvis, and this one is smack dab in the middle between pushing the rectum one way, pushing the prostate and the bladder another way. And this is another example where I'd need a urologist, or in other cases a gynecologist, to help with some of the reconstruction component of the operation. So another area that surgical oncologists tend to focus on is research and clinical trials, and this certainly is a passion of mine. I would say the majority of surgical oncologists also have a focus or passion in research and clinical trials. We get some additional training in that area as well during our fellowship, and most of us are committed to advancing the science of cancer treatment, and we all recognize that surgery is one component of it, and in fact it's still a fairly crude component of it. Most of the other advances are going to be coming from better understanding of biology and treatment of those tumors from a medical standpoint. And right now, the majority of surgical oncologists are affiliated with the academic center, but I would say that as the numbers continue to increase through the training programs, we're going to see more and more of them in the community, and that's a good thing. As specialists or specialty improves, I think people will understand more of the role out in the community as well. Now, I'm going to tell you a little bit about what I'm particularly interested in, and that is understanding how the immune system interacts with tumors, or how tumors impact the immune system. And there's a lot of data out there that really shows that tumors do suppress an immune response. Many times a tumor is recognized by the immune system as not belonging there, trying to get rid of it. But tumors figure out ways to avoid that immune detection. And that's what I'm really interested in. So we spend a lot of time studying some of the cells in the immune system that protect the tumor, if you will. The tumor will recruit some of these myeloid-derived suppressor cells or regulatory T cells, and those cells actually prevent an active immune response from going forward. And so we're very interested in understanding how that happens, and then figuring out ways to prevent that from happening. And I've run now a couple of investigator-initiated clinical trials specifically targeting those immunosuppressive cells. And if we can get those cells out of the equation, and then let maybe treat them with immunotherapy, or let the native immune response go forward, then perhaps we'll have a better long-term outcome. And the other area that I'm really excited about now is something called tumor infiltrating lymphocytes. And this is an area where we'll remove a tumor and then extract the immune cells that have infiltrated into that tumor. And we'll take those cells and we'll grow them in the lab to try to expand the number of active cells. And then we'll reinfuse them back into the patient in combination with interleukin-2 or interferon, some other therapies to try to stimulate a better immune response. This is right now considered an experimental therapy, but I would imagine in a few years it's going to become a mainstay of treatment, particularly for patients who have failed all other cancer treatments. And you know, right now it's kind of the last ditch effort, but you know, there's some, I think, very exciting evolving science behind those infiltrating lymphocytes that we can harness and utilize. So the next thing I thought I'd do is just give you an example of one of the types of operations a surgical oncologist will do. This is just a brief picture that shows the steps of a minimally invasive esophagectomy. So, you know, historically, we had done this with a pretty major operation on the abdomen and on the chest with big incisions. And it was designed to, you know, remove a tumor in the esophagus. This is where the tumor is located. And I'll show you this picture because the video I'll show you doesn't show you the outside so much, it shows the inside. But basically, what we're going to do is try to prepare the stomach for, you know, removing the tumor and then reconstructing the esophagus. And that here's some of the laparoscopic instruments there. The tumor is up here, so we're trying to exclude that part of the stomach, but save this part here. And then working with a thoracic team, they'll come in and bring the stomach up into the chest, and then ultimately connect the stomach to the esophagus high up in the chest. So I'm going to briefly switch over here to another screen and see if I can get the video to run here. There we go. Whoop. Can you see that video running?
No, we can't.
You can't. Okay, let me stop that and restart it here. Go back to my screen share. Here we go. All right, let's try this one. That should work a little better. Is that better?
Yes, you got that.
All right. So this is that operation there. We start by looking in the esophagus with the gastroscope. Now we're working in the abdomen to release the fatty attachments to the stomach and clear all the tissue away from the stomach and remove it from the diaphragm as well. And in this case, we're now taking off some of the fat around the lower part of the stomach, trying to preserve the blood supply to the stomach as much as possible. And we'll come back up here looking, this is the liver up here. This tumor is actually behind this tissue in here, so we're working around that. This is where the lymph nodes come into play. Those are lymph nodes around the draining area of the esophagus and upper part of the stomach. So we'll divide that area. We'll collect a few more of the lymph nodes to assess has the tumor spread to those nodes or not. And then we'll start to prepare the stomach here. So it's a little bit like doing a gastric bypass operation in some ways. We're going to be excluding this part here where the tumor is located. And then we're going to look up, you know, into the chest cavity here a little bit now. And that's where the tumor is right here. We're trying to get clearance of that tumor. After we've done that part, we can put a feeding tube in to give them some nutrition while they're recovering. And then we'll turn and put the patient in a different position and go into the chest cavity. Now you're looking into the chest area here with the lung being pushed over to the side. We're dividing some of the blood vessels in the chest. And now we've gotten around the esophagus in the chest area. And we're going to lift that up here. The tumor still is down in the lower part of the esophagus behind the lung there. And we're going to, you know, free the attachments to the esophagus and collect some more lymph nodes in this area. And then ultimately, here's some more of the lymph nodes being removed to better station. Ultimately, we're going to divide the esophagus up in the chest. So now the esophagus is way up here. I put a little stapling ring into the end of the esophagus here. And then we're going to pull the stomach up from the abdomen. And ultimately, we're going to make a connection between the stomach and the esophagus there. The tumor is somewhere in this middle part of this stomach. So again, this is the normal stomach here. We're going to now connect that part of the stomach to that part of the esophagus using this stapling device. And once that's done, that's the connection between the two areas. We'll then go ahead and completely take off the remaining part of the stomach and remove that. So part of the stomach, part of the esophagus, and all the lymph nodes all come out with this specimen here. And then we'll just take some of this fat that comes up with it and kind of protect that area where we made the connection. We'll put a chest tube in to drain the chest. And then we'll reinflate the lung and complete that operation. So at the end of the day, we were able to make reestablish continuity and a connection for that patient. Get back to my other screen here in just a moment. There we go. Hopefully that does that. So, I would say that I have the best job in the world. I just can't imagine a job that has as many fulfilling parts to it. I get to work with, an incredible team of other physicians to be creative about finding ways to try and treat a tumor or give that patient the very best chance at a cure. It is an incredibly impactful job to be able to remove those tumors and, if not provide a chance at cure, at least improve the quality of life of that patient. And it also involves so much in the, education of, not only patients, but students and residents. Also involves, participating in research and advancing the field of cancer treatments. And, all of that together are tremendous. And so with that, I'm happy to end the conversation here, or my part of it, but happy to answer any questions you may have. And maybe if I go stop screen share, I might be able to see the comments here.
It looks like there was a question, has there been any innovation that labels the margin of tumor to assist surgical resection?
Well, yeah, there are lots of efforts in trying to do that. It turns out to be a fairly tricky thing to do. And in fact, it's a very insightful question because margins are a huge part of what we try to do. Obtain a negative margin. And often you don't know that until you make your best guess. You make your cut and assume that you've gotten a negative margin, but then you have to wait for the pathologist to look at it. Sometimes they can look at it, what's called a frozen section, real time, and then tell us, yep, you need to take more. Sometimes you don't get the final answer for a week or so until they've had a chance to go through all the different areas of the margins. There have been a few devices people have tried to develop to improve our ability to get an accurate margin. There have been a few attempts at using antibodies to label cancer cells in the person. So maybe a fluorescent labeled antibody that sticks to the tumor, and then you use a fluorescent light to guide yourself on where to place your incision. These have been somewhat helpful, but not a perfect science yet, and definitely an area ripe for the right combination of people to come up with a better way to do that.
Looks like another question was, do you do surgery for ocular melanoma?
Good question. I personally don't. So an ophthalmologist does that, but we see a lot of them at our melanoma multi-D board. And we work with ophthalmology. We have our medical oncologist, and occasionally, if the ocular melanoma is spread to other places, occasionally a surgical oncologist will get involved with that. But obviously, then that tumor is spread elsewhere, and it's a little bit harder to treat it at that point.
The next question up here is, what tumor types are you utilizing? Isolated, expanded, TILS?
Yeah. So, right now, the clinical trials for the TILs, tumor infiltrating lymphocytes, have been run in melanoma and in cervical cancer. We are expanding that now. Recently, head and neck tumors have now been studied in this as well. And I would suspect that that type of technology is going to be, if you would, tumor agnostic. It really won't matter what type of tumor it is. What we're really after are the immune cells, right? And so, if we are able to extract some of that tumor and then remove the tumor cells or the infiltrating lymphocytes in there, and then grow those lymphocytes, it shouldn't matter. And that's actually kind of one of the poster childs for personalized medicine, because you're actually taking that patient's own immune system, growing it in the lab, making it better, and then putting it back. And that own immune system recognizes that own tumor as opposed to somebody else's tumor. It's, any one person's immune system may not recognize a different person's tumor. So, it really is an exciting area from a personalized medicine standpoint and from a science and technology standpoint.
What is the survival rate for a typical patient that would undergo this procedure?
Yeah, so I assume that's referring to the esophageal tumor. So, we got a long way to go. If it weren't for pancreas cancer, esophageal tumors would probably be the bad actor here. But so for all comers with esophageal cancer who can have an operation, and by the way, it's estimated maybe half can have an operation because the tumors are often spread before then. But let's say the tumor is not spread, it's localized in the esophagus. We will typically treat them up before an operation with a combination of chemotherapy and radiation therapy, and then go to surgery. If that patient gets through all of that, only about half of them will be alive at 5 years. That means the other half, the tumor will come back, and most of the time it's not because of a bad operation. The tumor comes back because they had microscopic tumor spread someplace else that we couldn't see at the time of their original diagnosis, and it wasn't destroyed with the chemotherapy or radiation therapy that were used either.
Is there work on how the tumor microenvironment obscures the tumor margin?
Well, yeah, that's also another good question. We're learning a lot lately about the tumor microenvironment. So the tumor has a way to alter the surroundings, and one of the ways that I'm focused on is the immune signature there. But it does a lot of other things too. It creates this sort of fibrotic scar tissue environment around the area. And that is one of the things that can be difficult to discern at the time of an operation. Sometimes patients have just a tissue reaction around it. Sometimes they have an immune reaction around it. And sometimes it's a scar reaction. And knowing exactly where the scar is versus tumor is can be very difficult. And the other thing we're learning too is that the microenvironment very much affects how effective treatments are, and we know in particular pancreas tumors have a very dense environment, very hard to deliver effective chemotherapies to that area, for example, and lots of work going into trying to understand that microenvironment, break down that microenvironment, and allow better therapies to get there.
In terms of stopping tumor growth, since they do have long histories, are you aware of any research involving angiogenesis?
Angiogenesis.
Yes,
Yeah.
not allowing a tumor to grow.
Yeah. There's a lot of interest in that field as well. So angiogenesis refers to growing new blood vessels. Angio is blood vessel, genesis new. And tumors have to grow new blood vessels to survive, right? To grow, rather. They might start out very small, but they'll eventually need a better blood supply if they're going to grow bigger. And so a lot of folks are interested in trying to attack that new blood vessel growth, the angiogenesis that the tumor is relying on. As you can imagine, it's kind of a tricky field because we need the blood supply to all the other areas of your body, but you don't need the blood supply to the tumor, right? And so how do you target just the blood supply to the tumor? That's really where the rub is. Again, there are a bunch of agents that we know inhibit angiogenesis, but getting them targeted or delivered locally is really the challenge.
Does the surgical oncology team utilize the Da Vinci robot for some of the surgeries?
Yeah, we do. So that video I showed you actually was a laparoscopic esophagectomy. We do the same operation with the robot now. And then we also use the robot for a number of other ones. Low rectal cancers, for example, another area. My partner, Dr. Gleisner, has been doing the robotic liver resections for a number of years now. And really, the Da Vinci robot is a great tool in many positions. It may not always be the right answer, but it has certain advantages. And some of the optical, close-up view is really helpful. And then being able to work in a very small space is helpful. So for the esophagus, that's been very helpful for us. Low in the pelvis, it's very helpful. Just as it is for gynecologists and urologists, working in the prostate and uterus, it helps to have the advantages of the robot there.
How do you deal with
Lymphangiogenesis, yeah.
Yes, around the tumor, since it is less visible.
Yeah, so lymphangiogenesis refers to lymphatic growth or new lymphatic growth. And again, tumors have ways to create new lymphatic growth. And you might ask, well, why do they need to do that? Well, it's very much related to angiogenesis, growth of blood vessels. But it's also, in my opinion, a way that the tumor uses to hide itself from the immune system. So, if it develops its own lymphatic system, well, that's kind of educating the immune system to say that this belongs here. This should be normal. You should not attack this tumor. And so the other part of it is that lymphatics are a way that tumors spread. So if the tumor can grow its own lymphatic system and then shed cells into the lymphatic system, it has a chance to grow and spread to other locations. So just like, in the angiogenesis world, there's a whole bunch of researchers, not only on this campus, but elsewhere, who are trying to figure out how do we stop that lymphangiogenesis process. And therefore, how do we shut down the ability of the tumor to spread or shed through the lymphatic system. As far as visualization, that is super hard because even under the microscope, lymphatic vessels are often difficult to truly identify. And so, from a cancer standpoint, depending on what type of tumor we're dealing with, we know which one's more likely to go through lymphatics or not, and we'll change the operation based on that. So if it's got better chance to spread through lymphatics, we're going to extend the operation. That's going to include a wider margin around the primary tumor. It's going to include the lymph nodes that drain from that tumor. And that's, many times why, huge operations have to be done for small tumors is because of some of these other abilities to spread.
What are your thoughts on the proposed idea that some local recurrences of tumors are actually a metastatic process?
Yeah, that's a very insightful question too. It turns out it's a very difficult one to truly study down to the level that you could confidently say it's, it is or is not metastatic versus local. The other element here is that tumors or cancers have been called, are basically a wound that doesn't heal. So, if you make scrape yourself, your body's going to heal that, right? It's got this process of first the immune cells go in, then the scar tissue repairs, and the new cells, take it over. Well, basically that's what a tumor does too. It has that same sort of sequence of processes, only it just never heals, right? And the tumor just figures out a way to keep growing. And so it's possible that you might have some, let's say, some circulating tumor cells that, if there were not a fresh healing, fertile garden to set up in, may never be able to grow again. But if they happen to land back in the healing wound, well, that's a great place to set up shop and get all the nutrients and support system you need to grow. So there are experimental results that say that contributes to local recurrences. And then, there's other possibilities, because although we, rely on, pathologists to assess the margins, the reality is you may not be able to assess every single margin, right? They take their best chance and look at the closest margins, and they slice off a few pieces of tissue and look under the microscope. And if there are no cancer cells, that's considered negative. But who's to say that right next to where they looked, there might not have been a cancer cell or two? And so, whether that's local recurrence setup shop or some circulating metastatic cell setup shop, can be very difficult to sort that out.
Okay, thank you. Do we
Right.
have any other questions, or if you'd like to unmute yourself to ask them, that's fine as well.
Yeah, thank you for those. Those are very good questions. I appreciate that. Hope you learned something.
Well, thank you, Dr. McCarter. That was a wonderful presentation, very interesting and insightful. If we don't have any other questions, then I guess we could go ahead and wrap up. If you haven't